these things, all right? So we're going to start with the basics. We're going to go over these basics every class, then we're going to do deeper dives, and we're going to go into different subjects like I mentioned. So let's start with some orientation terms. I invite you to stand up and move with me. You certainly don't have to. You can sit or lay down in your bed, whatever's comfortable for you. Do as you like. So let's get oriented first. So distal means away from the center. So my hand is distal to my hand is distal to the center of my body. The center of my body is proximal to my hand, right? And distal is relative. So my elbow is distal to my shoulder. My shoulder is proximal to my elbow. So everybody say that along with me. I know the mics are off. So the elbow is distal to the shoulder. The shoulder is proximal to the elbow. The elbow is proximal to the wrist. The wrist is distal to the elbow. Now there are 3 joints in the finger, and this is kind of a handy way to remember these, right? So you have the proximal phalangeal joint, you have the distal phalangeal joint, and you have the interphalangeal joint. Proximal, inter, and distal. Okay, and let's look at the lower part of the body too, because that also will help you. Let's see this one. Okay, so know that the limbs on the lower part are also, this is the first time I'm doing like 2 cameras, okay? So this is the center of the body, and this is the limb, right? So the knee is distal to the pelvis or the abdomen, right? And the abdomen is proximal to the knee, right? The ASIS is proximal to the knee is distal to the ASIS. So try that. The knee is distal to the ASIS. The ASIS is proximal to the knee. The knee is proximal to the ankle. The ankle is distal to the knee. And in the toes, there are also those 3 joints that there were in the fingers, right? There's the proximal, the interphalangeal, and then the distal joint. And so also the finger or the tip of the finger is distal to the knuckles, and the knuckles are proximal to the fingertip. Proximal because it's coming toward the center of the body. Okay? Okay, and then we have a couple terms which we always need to clarify, or we always need to refresh our memory. So we have then medial and lateral. So medial and lateral are the same thing. So when we say, medial and lateral are not the same thing. Medial and internal are the same thing. So medial is towards the midline or towards the median of the body, and then lateral is away from the midline, like towards the, right? So this would be lateral out here away from the midline. Lateral out here away from the midline, and then medial is towards the midline. Okay, and then you have anterior surface of the body, and then on the back you have the posterior surface of the body, right? So anterior surface, posterior surface, right? This is also called the ventral surface and the dorsal surface. So everybody like touch the front of your shoulder, the deltopectoral triangle, and say to yourself or say out loud, this is the ventral surface, this is dorsal. Let's do a couple different parts of the body. So this is the ventral surface or the anterior surface of the cranium, posterior surface of the cranium. This is also called the occiput, right? So anterior, posterior, ventral, dorsal, right? Anterior, posterior, ventral, dorsal. And for the pelvis and the lower limb, it would be anterior, posterior, anterior, posterior, right? Also called ventral and dorsal, ventral and dorsal. Now for the hand and the foot, there's also anterior and posterior. Oh, I should show it to you this way. I'm so sorry. So anatomically correct looks like this. So when someone says, tell me about or indicate the anterior portion of the hand, you should imagine the body like this, not like this. which is actually like a classical acupuncture position that they have for one of the meridians, which is pretty cool, but that would be incorrect. Okay, so this is anterior, front of the body, ventral, front of the body. And for the hand and the sole of the foot, there's also two different terms, or one different term, and that is volar. Volar for the anterior surface. So volar, anterior, ventral, those are all the same. Also called palmar, right? Palmar. And then the posterior surface, or the dorsal surface of the hand and the foot are also called, the dorsal surface and the posterior surface, those are the same for the rest of the body. So the anterior surface is also called volar for the palm and for the sole of the foot, aka palmar for the hand, plantar for the foot, right? Plantar surface of the foot, the plantar surface of the foot. But the back, the dorsal surface, is the same. Dorsal or posterior surface is the same as the rest of the body. Okay. The planes are also something that we need to review regularly, right? So if you look on the screen, raise your hand if you cannot see the screen. I'm circling around this drawing of the planes, right? Purple, red, yellow, and green. It's very small. So we have the frontal or the coronal plane. The frontal or the coronal plane is said to divide the body into the anterior and posterior. That's kind of confusing. So I would like you to move, right? So this is the frontal plane. This is movement in the frontal plane, right? And mainly what the frontal plane does is abduction, abduction, and adduction. And we will be covering all of these again. So this is the frontal plane, abduction and adduction. It's also side flexion through the neck. This is the frontal or coronal plane. Side flexion through the trunk or through the rest of the spine happens in the coronal or the frontal plane. It also covers the abduction and the adduction, okay, abduction and adduction of the lower limb. And that is the frontal and coronal plane. Frontal and coronal plane is to start like from the beginning of the planes, right? The frontal and the coronal plane, it goes this way, right? So the frontal and the coronal plane is actually the one responsible for, or that contains adduction as well as abduction, abduction and adduction. Remember that adduction is adding toward the midline. My appendages are coming toward my midline. Right, and abduction is abducting away from the midline. The frontal or sagittal plane also does side flexion through the neck, and it does side flexion through the spine. In the lower body, the frontal or coronal plane likewise would do abduction and adduction. When you read and when you study, I recommend you say abduction, adduction, like really carefully. I cannot tell you how many times I and lots of other people have missed those. And if they don't let you re-answer things on the MBLEx test, which is kind of silly. So it's abduction, abduction, adduction, adduction, right? Here's the midline. Right? The midline goes from here, up through the center of the body, all the way up through the glabella, top of the head, midline. Okay, so speaking of the midline, there is a plane which goes straight down the midline, and that's variously called the sagittal, the longitudinal, or the median plane. So this is the sagittal plane right here. So if you draw this like thick orange sheet through the body, like more or less bisecting the body into left and right, you would see that the movement that happens in that plane contains flexion and extension of the neck, as well as flexion and extension of the spine, flexion and extension of the spine. It also contains flexion of the shoulder, and then extension of the shoulder, right? Flexion and extension of the shoulder, flexion and extension at the hip joint, flexion and extension through the lumbar spine, right? And it also contains Also contains flexion at the hip, extension at the hip, okay? Flexion at the knee, extension at the knee. And it also contains plantar flexion and dorsiflexion at the ankle. Okay. You have a question, Josephine? You need to unmute yourself. You're okay? Okay, great. Just unmute and call out if you guys have a question or if anything's like not clear, okay? All right, and then the horizontal or transverse plane. So the horizontal or transverse plane is a horizon. It goes this way, and we always see it in graphics, like going right through the midline, going right through the waist, but you can move that plane all the way up to the eyes, the top of the head, the neck, whatever, right? So the horizontal or transverse plane would be the one responsible for allowing us to turn, to rotate, like that, right? It also would allow for what's called cross flexion or cross adduction, cross extension, cross flexion, cross abduction, cross abduction, cross adduction, right? And then it allows for any kind of twisting or torsion through the spine, twisting or torsion through the hip joints, also for external rotation through the shoulder joint, internal rotation through the shoulder joint, external and internal rotation, external and internal rotation through the hip joint. Is that everything? Yeah, that's everything. Great. Okay, so, and just a good practice thing for you to do, like every day, would just be to use like your head and neck or your arms. So you could just go frontal, right? And then medial or sagittal, and then transverse. And if you just did that, that would be like really reinforcing it in a kinesthetic way, much more so in your mind than most people usually do. Most of us know these, but when it comes time to take the test, it's abstract to look at it on a piece of paper. You want to be the person, I want you to be the person in the exam going like this, right? I want you like guys doing that. Because it will really help. Okay, we got into some of the joint movements already. A lot of people, they don't really know the joint movements. We're not going to go through all of them tonight. We'll do some tonight, some on Thursday, and we'll cycle through them like that. Okay, so we have flexion and extension. Let's start like with the larger joints of the body, and then we'll go out to the smaller joints, but let's do all the flexion and extension tonight. So the flexion and extension of the neck looks like this. This is flexion. This is extension. And the neck can be confusing to some people. They say, well, flexion is when we close the joint, right? Like they think about a joint like the elbow joint. And here I'm closing the joint all the way, right? The two bones are coming toward each other, and I'm opening the joint when I extend. Two bones are going away from each other. So if I apply that to the neck, by the same logic, how come this is only flexion? I mean, isn't that actually technically extension in the back of the neck? And isn't this technically flexion in the back of the neck? Well, the answer is because this is the anatomical position, right? So you always image the body from this position with the palms forward from the front surface of the body, also called the anterior or the volar surface or the ventral surface of the body. Just gonna take a breath for a second. Okay. So flexion happens when you close the front surface of the body. Imagine that the vertebrae are going like this right now. We're going like this. And so this is flexion in the neck, and then flexion in the thoracic spine, and then flexion in the lumbar spine. At the hip, flexion would look like this. Right? Right? And then flexion starts to get a little bit more complicated as we go from the center of the body out. Distally, right? Remember that this is proximal and this is distal. Yeah, proximal and distal. So flexion for the shoulder is a little bit, in my opinion, a little bit unique because these other joints, when we flex them, it's kind of obvious we're bringing the bones towards each other, but the shoulder joint, it's just raising it towards the front. It's kind of difficult for me to imagine closing the joint in the same way, bringing the bones together in the same way as like the elbow. this is flexion, right? This happens through the sagittal plane. Flexion of the shoulder happens through the sagittal plane. So this is flexion of the shoulder, and this is extension of the shoulder. This is 0. Why is this 0? Because this is anatomical position. Right? So flexion and extension of the shoulder. All right, and then flexion of the elbow and extension of the elbow. Right? And then flexion of the wrist and extension of the wrist. Right? And then flexion of the fingers and then extension of the fingers. And then for the hip, it's similar. For the hip, it's flexion at the hip, neutral, tension at the hip. Right? So you all should be doing this in some way, like in your chair is fine, right? Flexion at the hip, extension at the hip. Right? Extension at the knee, flexion at the knee. Right? And this is called plantar flexion and dorsiflexion. So the dorsum of the foot is dorsiflexed, bottom of the foot, the plantar surface is plantar flexed. Okay. Oh, and the toes. The toes are extended and then flexed. Right? But you could also just say dorsiflexion and plantar flexion. You don't really need to be like so particular about the toes and the fingers for the test, right? Right? And clinically, as long as you can visualize the movement and you understand, somebody says, "Oh, when I do this or when I do that, it's painful." You know which surfaces to explore. Okay. Abduction, adduction, and then let's do supination versus pronation. Okay, so abduction, like I discussed earlier, AB is abducting, right? So abducting, always think of the center line, guys. Think of the center line, right? So we're abducting away from the center of the body, and then we're adducting toward the center of the body. Right, so I'm abducting the shoulder abduction. This is still shoulder abduction. It's about 175 degrees in my case. Right? And this is neutral, and this is shoulder adduction. And then for the hip or the leg, it's the same. So it's abducting, adducting, abduction, adduction, right? And the plane that goes this way is the frontal or coronal plane. So this is movement. So this is movement through the frontal or coronal plane using abduction of this leg and then adduction of this leg. All right. Let's see. Abduction, adduction. Oh, so if you just go like this, like in the beginning of your study session, okay, this is abduction, this is a deduction, right? This is flexion, this is extension. You know, do all that in the lower body, maybe one or two in the distal limbs, in the elbow and the knee. That's fine. But then when you look at the body from the center, from the midline, there is no moving away from the midline. Start on the midline. So while we may be used to thinking of this as shoulder abduction, this is not moving away from the midline as in abducting the head at the neck. This is side flexion because it's veering off of the midline but still connected to the midline is how I can think about it, right? So that's side flexion. This is side flexion. This is not abduction. This is not adduction. Okay, and then supination and pronation. So supination and pronation is something that can happen anywhere in the body. It really just depends on the horizon, the actual horizon, not like an anatomical horizon. So just think of it as carrying a bowl of soup. Nobody carries a bowl of soup like this. It's huge. Carrying a bowl of soup and then prone to spill it. Everybody, raise your hand if you don't know what the word prone means. Prone means having like a tendency to or like really, really likely you're gonna do something. So this is prone to spilling it, and this is carrying a bowl of soup. Carrying a bowl of soup, supine, prone to spilling it. And so The hand can be supinated or it can be pronated. The body can be supine, laying on the back, face up on a massage table. It can be prone, laying face down on a massage table. Also, the foot. This is important. There are three movements in the foot we'll go over later. But in the foot, there is supination, because if we continued in this direction, the plantar surface of the foot would be face up, right? And that would be like carrying a bowl of soup, right? And if we went the other way, this would be moving towards prone. And the confusing thing about the foot is that we always imagine the foot starting in anatomical position, which is plantar surface down or neutral, right? So from neutral, this doesn't look like much, but it is supination. Just imagine the movement continue supine. And starting from neutral, this, also called eversion, certainly doesn't look like much, but that is definitely pronation. And if you continue this way, the dorsal surface of the foot would be facing down, facing down, yeah. Up. Dorsal surface would be facing up. Sorry. So, what time is it? Okay. Let's move on. Yeah. You guys see what I'm doing with the joint movements? I'm graying out the ones that we did this week so I know where we stopped. Okay. A lot of these movements down here we did already. Lateral flexion of the neck and the spine. That's to explore what plane. Just say to yourself what plane happens for lateral flexion. That is the frontal or the coronal plane. And then horizontal abduction, horizontal adduction I mentioned earlier. Horizontal adduction looks like this. Horizontal abduction goes this way. Horizontal abduction, horizontal adduction, compared to regular old abduction, adduction, abduction, adduction. Horizontal adduction, horizontal abduction. Not to be confused with a deduction, which may look like this. This is just a deduction because we're starting from here. But if we start from a semi-flexed position, then go this way, that's horizontal movement. Whereas this is frontal or coronal movement. Horizontal transverse plane, frontal coronal plane. Let's see. That happens in the shoulder only. Horizontal abduction, horizontal adduction is in the shoulder only. Diagonal abduction, diagonal adduction also happens only in the shoulder. And that just looks like this, right? So this is horizontal adduction because I'm moving toward the midline, right? And this is horizontal abduction because I'm moving away from the midline. So starting at the midline, moving away horizontally, that's abducting. Moving towards, that's adduction. Even if I move past the midline to touch my opposite hip, like that's still horizontal adduction. And then there's circumduction. Circumduction can happen at any joint in the body which allows it, and we'll be covering the different joint types. But you can imagine circumduction as being like a cone, or kind of like a pine tree. Pine trees are shaped like a cone, right? So the distal most portion of the appendage, whether that's the hand or the foot or the vertex of the skull, the distal most portion draws a large circle. And the proximal most portion, where it connects to the torso or to the center of the body, makes a pinpoint or an axis, right? So there's the wide base of the cone out here, right? And there's the tip of the cone here. So that's circumduction. And circumduction involves variously some aspect of flexion and extension. It also involves some abduction and adduction, flexion, extension, abduction, adduction, and sometimes it can include supination and pronation, but it doesn't have to. The result is a rotation where it meets the center of the body. So my arm is rotating with the axis, the center of the rotation being at the shoulder. And now with the head, you guys should all try to do this. The vertex of the head is drawing the large circle of the cone, and the center point of the cone is at the base of the neck. Right? And then do that with your wrist. Your wrist can also do circumduction. So the point of the cone is at the wrist. The large circle of the cone is in the fingers. Right? And then you can do that with the hip. Just look down. You can see it done with the hip. And you can also see it done with the ankle. And different types of joints allow for circumduction, and other types of joints do not. And we'll be going over those different kinds of joints. Okay, here are some references right here. If you can see on the screen share, here are some references that you guys can use to look at some of the joint movements. There's a good one on shoulder joint movement through Ace Fitness. There's a great video, Anatomy Heroes Muscle Names video. I'm not sure what that's doing. It's not in the right section. Anyway, massageschoolnotes.com/joint movements. That's a good reference. Okay, great. Now let's cover eccentric and concentric. Okay, so concentric and eccentric. So the way that okay, let me just show you concentric and eccentric first. Okay, so the easiest place to show concentric and eccentric is through something like the bicep, because it's really easy to see the bicep and the tricep. So concentric contraction of the bicep brings the forearm toward the shoulder. It closes the joint. Right? At the same time, the tricep is contracting eccentrically. So this is concentric contraction of the bicep, eccentric contraction of the tricep. So you should be touching and saying and moving concentric bicep, eccentric tricep, and then extend concentric tricep, eccentric bicep. Now, how are you going to remember that? And in some places it will get tricky. So the way that I like to remember that is remembering that the muscle fibers go this way, right? And when the muscle fibers shorten, they're going the same direction that they're built. Right? They're built to move this way. So right now the fibers are going like this. The two ends of the fibers are coming towards each other, and that draws the forearm toward the humerus, forearm, humerus bone, right? And then going away, and then extending the elbow joint, the fibers of the bicep are moving away. They're moving away from each other. So this is lengthening, moving away, and shortening, moving towards. Con means towards. EC, like eccentric, means away. Right? Don't try to memorize. Okay, this bone is moving towards the center of the body, and now it's moving away from the center of the body. Because by the time you get to something like the shoulder, you're thinking about, okay, is this concentric contraction of the anterior delt? I can't really tell. It just gets a little bit tricky there, right? And same thing with the neck. Sometimes it's hard to remember that this is concentric and this is eccentric. Just keep in mind that the fibers, visualize the fibers. Which way are the fibers going? Right? The fibers right now are going this way, and they're shortening. That's concentric. Now they're going away from the two ends, away from each other, lengthening. That's eccentric, away. Right? Concentric in the bicep, eccentric in the bicep. If you can remember that, concentric and eccentric meaning toward and away, you'll always, and you can visualize the fibers, you'll hopefully never get it wrong. So let's do concentric and eccentric in a few different places that are the more common. We just did neck, so neck flexion. Remember, we always see the body anatomically from the front. The anatomical view is always from the front. So neck flexion means that we are concentrically contracting the neck flexors. We're contracting the muscles in the front in the anterior ventral volar surface. And then anterior and ventral surface, not volar. Sorry, volar is only for the palm. And then extending the neck means that we are contracting the extensors concentrically. Okay, so in extension, we have eccentric contraction of the extensors. I'm sorry. In neck extension, we have concentric contraction of the extensors in the back. We have eccentric contraction of the flexors in the front. With neck flexion, we have concentric contraction of the flexors in the anterior, and we have eccentric contraction of the extensors in the posterior. And then for the abdomen, I guarantee they're going to ask you about like abdominals, hip flexors, spinal erectors, and all that. So for the abdominals, this would be flexion, right? Or this would be flexion in the abdomen, right? So this is concentric because the fibers are going this way, right? The two ends of the fibers are going like that. Can you guys visualize that? Raise your hand if you cannot. Great, awesome. So with flexion, there is concentric contraction in the abdominals, eccentric contraction in the SEGs, the spinal erector group. And then with extension of the spine, there's concentric contraction of the SEGs and eccentric contraction of the abdominals. Then for the hip flexors, right, the hip flexor fibers, they go like this. They go in this direction, right? So the two ends would be moving like this, the concentric contraction, which would bring the leg up, or it might bring the ASIS down to the leg. Okay? So this is concentric contraction in the hip flexors, concentric contraction in the hip flexors, eccentric contraction in the glutes and the hamstrings. Right? And if we go back toward neutral, you have concentric contraction in the glutes and hamstrings, eccentric contraction in the hip flexor. Concentric, eccentric, concentric, eccentric. So one of the questions we're going to look at is a patient comes to you and injured herself kicking a soccer ball to the front. And where was the concentric contraction? Where was the eccentric? Was it eccentric in the glutes, concentric in the hip flexor, etc.? And then we go through four multiple choice questions. Right? And so you have to know, okay, if this is the ventral surface of the body and she's kicking it anteriorly, ventrally, then the contraction would be happening with the fibers in the front, concentric, and away from the fibers in the back, that's eccentric. Then we probably will see when we did the bicep and the tricep at the humerus. So now we're going to do the rectus femoris in the front and the biceps femoris in the back, also known as the thigh muscles or the quads in the front and the hamstrings in the back. All right, so if we do flexion at the knee, that's concentric contraction of the hamstrings because the two ends of the hamstrings are like this, and now they're moving towards each other. And eccentric contraction of the rectus femoris. And if we extend the knee, we're doing concentric contraction of the rectus femoris and eccentric contraction of the hamstrings. And then for the foot, if we dorsiflex the ankle, we're doing concentric contraction of the calves and eccentric contraction of the tibialis anterior. And if we plantar flex, I'm so sorry, if we plantar flex, we're doing concentric contraction of the calves, eccentric contraction of the tibialis anterior. If we dorsiflex, we're doing concentric contraction of the tibialis anterior, eccentric contraction of the calves. Everybody say that. Concentric contraction of the tibialis anterior, eccentric contraction of the calf muscles. In dorsiflexion, concentric tibialis anterior, eccentric calves. Plantar flexion, concentric calves, eccentric tibialis anterior. Plantar flexion, concentric calves, eccentric tibialis anterior. Okay. By the time we start getting into like the latissimus dorsi versus the pectoralis muscles, stuff like that, it can get like a little bit not intuitive, but it's also not complicated. You just have to see it a couple times. We'll be doing concentric, eccentric each class. It'll look more like this, right? Forearm flexors concentric, forearm extensors eccentric, forearm extensors concentric, forearm extensors eccentric, tricep concentric, tricep eccentric, tricep concentric, bicep eccentric. And I want you guys to all be like repeating after me, and I'll give like a little pause so you guys can all do that. Okay, this is here on the page. If you look at the screen share, I just want to point something out about these concepts of anatomical versus physiologic range of motion, and also plasticity versus elasticity versus extensibility. So your anatomical range is the range of motion that your bones and your ligaments, in other words, your joints, because joints are made up of bones that meet and the ligaments that hold them together. The anatomical range is what your joints allow you to move. It's how you're built to move, right? It's your natural full range of motion. Don't forget that flexibility includes both the joint range of motion and the soft tissue. So hopefully that is familiar to you, right? So if you do a job or you do work that involves like a lot of use of the wrist, the forearm muscles and the tendons from those muscles, they can get really tight. And even though you may have, let's say, I've got like 90 degrees of wrist flexion, okay, even though you may have anatomically 90 degrees of wrist flexion, at the end of a long day of using your hands, you might only have 80 degrees of wrist flexion. That's called physiologic range of motion. It's when your nervous system tightens things up or loosens things, and it changes the anatomical range of motion. So the anatomical range is the amount that your skeleton, your joints, your ligaments are built to give. The physiologic range is the amount that the nervous system is allowing at the time. If you sprain your wrist, if you repetitively strain your wrist and forearm, you will have a smaller physiologic range of motion than your anatomical range of motion. If you have a stiff wrist and you stretch and you do mobility exercises, you'll be restoring your anatomical range of motion, bringing your physiological range of motion closer to the anatomical range of motion. I got to stop looking at this thing. I see you guys over here. I got to look more there. Sorry. Okay, anatomical versus physiologic. This concept might only appear one time on the MBLEx, but if you miss one question, it's still a question list, right? Plasticity versus elasticity versus extensibility. You're going to see this like twice, 3 times, 4 times across the exam. So extensibility is the property of being extensible. That means something that can lengthen and shorten. It can change the shape. Right? So our fascia, our musculature, in theory, even I guess that would apply to the joints. A lot of our internal organs, they have extensibility. They can stretch if we stretch them, and they can stretch if we stretch them. They can contract if we contract them. So my biceps muscle is demonstrating extensibility right now. It's lengthening and now it's shortening. That's a property of extensibility. It can do both of those because it has extensibility. Elasticity is the property of stretching, lengthening, and then being able to return to its original state. So I've been working on stretching my triceps and my elbow joint to get into this front rack position for lifting. And my elbow and all the tendons, the soft tissue, the fascia, and the ligaments, they all have the property of extensibility. So I can get more flexion in this position because I have extensibility. And therefore, I will retain some of that additional range of motion for a time. Now, after a few days, my range of motion will start to decrease, right? I won't be able to close that joint as much. The decreasing in the range of motion, the return to the natural kind of default tone or default range of motion, default flexibility, that's elasticity. I don't stretch it and then it stays there at its new length for the rest of my life. That's called plasticity. Elasticity is where you stretch something and then it returns to its original resting state, either after you let off the stretch or over time. That's elasticity. Like an elastic band, a rubber band, you stretch it and then it recoils, it goes right back. So one of the questions that we're going to see practicing is you're working with a client who has very tight hamstrings. You do some passive stretching. You stretch the client's hamstrings. But then at the end of the session, when you test the client again, you notice that the range of motion hasn't changed, even though when you're stretching, you can actually take the client much farther. At the end of the session, the range of motion goes back to where it was before. Is that plasticity, elasticity, or extensibility? It's elasticity, because you stretched the client and the client's hamstring went back, eventually rehabituated, returns to its normal state, which was tighter than where you stretched it. And then there's plasticity. Plasticity is a concept that applies to soft tissues as well as to the brain, because the brain changes shape as it learns, right? And so if something changes shape as you lengthen it or shorten it, that's the property of plasticity. So if you do shoulder shrugs, or if you work like this, which is a form of doing shoulder shrugs, if you work like this and your shoulders end up around your ears because your upper traps are contracted, that property is called plasticity. And over time, they will demonstrate elasticity by returning to normal. But for most people, they have to really work at it, right? Okay, let's move on. Anybody can draw the brain. Anybody can draw nerves. They can, you can draw parts of cells, and you really should. You should practice this. Like, I guarantee that if you draw it, it'll be another layer of learning for you to start to associate things. Your brain will learn much more deeply if you touch, have a kinesthetic approach, if you draw, having a visual approach, if you speak, having an auditory approach. Okay. So a nerve cell looks kind of like, in my opinion, looks like a tree with roots, right? So here's the roots that would go down into the ground. This arm down here is just showing you that these axon terminals would actually innervate or touch effector tissues in, for example, the arm is just an example. And then there's the trunk of the tree where all the xylem and phloem and nutrients and all that stuff flows, and that's the axon of the nerve. We're going to go over all of this multiple times every class. There's the axon of the nerve. A lot of nerves have a wrapping, which are these living cells called Schwann cells. Schwann cells or Schwann cells is spelled for you right here. SCHWANN, Schwann cells. And those are cells that contain lots of cholesterol and lots of fat, and they insulate sections of the axon in order to speed up the nerve transmission or the nerve impulse or the action potential transmission. A nerve impulse is an action potential, which is the movement of ions, which is the movement of electricity, which is the movement of charged particles, all the same thing. Movement of charged particles, movement of ions, movement of electricity, propagation of electricity, propagation of a nerve impulse, action potential, those are all the same thing. And you'll hear these terms, I'll make it a point to use those terms interchangeably a lot. Okay, and then at the top, there's a body, and then there's the branches of the tree. The body has all the same organelles that you would expect from other eukaryotic type cells. A eukaryote is a cell which has a distinct nucleus wrapped in membrane inside of the cell body. It has, lysosomes and riboplasms and a nucleus and all kinds of stuff, right? Because these nerve cells, they have to manufacture things like acetylcholine and dopamine, and they have to make all this stuff so that they can transport it down to the axon terminal or up to the dendrites and release it and give it to other cells. And these are the dendrites. So dendrite spelled like this. Dendrite, as far as I know, means or refers to tree, a shape that is like a tree. So you have like one big tree, and then you have a bunch of small trees coming out of the body, the dendrites. I'll only say this once because I don't need to like emphasize it. Whenever you have extensions coming off of something in the body, whether it's dendrites or whether it's an axon terminal or whether it's like the finger-like villi that we find in the small intestine, whenever you have those things, the purpose is to increase the surface area because all those finger-like extensions, all those dendrites, all those terminals, they're all like crayons, and every crayon has a wrapping around it. If you took the paper off of every crayon and flattened it and laid it out, the surface area of all of those crayons or all those crayon wrappings would be exponentially bigger than it would be if you just took the body and flattened out the surface of the body. And the body is all about efficiency, and you have to think about like in terms of surface area, like how that makes the body more efficient. Being able to touch more of a muscle or being able to touch more nerves in an area, like a ganglion or a synapse or a nucleus, allows the body to affect a bigger or more powerful change one time per, like theoretically, like one nerve impulse or one action potential, rather than having to send repeated nerve impulses or action potentials potentially through like several different axons, several different cells. Okay. When impulses are sent from the body or the dendrites down into the terminal, that's called, in general, actually, let me start over. When action potentials or nerve impulses go from the central nervous system to the effector organs out through the rest of the body, that's called efferent, and when they come back into the central nervous system, that's called afferent. We will go over this again many times. Okay, let's take a look at another drawing by someone, equally as talented, I guess. So we have the body of the neuron. We have the body of the neuron. Neuron is nerve cell, right? And then we have the dendrites coming off of the body. This drawing shows the nucleus. There would be, hundreds of other organelles inside, but it's just showing the nucleus inside the body. And then extending off of the body is the axon. Axon is very long. Its purpose is to allow the propagation of action potentials over great distances, greater than the body would allow anyhow. And it ends at the axon terminal. And along the axon, you find Schwann cells, which myelinate the axon. And to make a long story short, the Schwann cells, because they're fatty, they do not permit the movement of fluid in and out of the cell where they wrap the axon. You can also think of them as kind of like, excuse me, you can also think of them kind of like as something like plastic or rubber, that doesn't allow the movement of water, the movement of ions, the movement of charged particles in and out of the cell across the axon cell membrane. Excuse me. And as a result, the charged particles have to go in and out of the axon at specific places. So instead of the action potential or the nerve impulse going smoothly down the axon like this, what it looks like is it goes in like waves like this. And if you like summate, if you add together the distance of all the unmyelinated parts of the axon, the effect of the Schwann cells or the myelin sheaths, the effect of the Schwann cells is to take something that's long and make it really short. So the action potential propagates or moves in a way that's much quicker, at a rate that's much quicker. Body, dendrites, axon terminal, Schwann cells, which provide myelination. Unmute yourselves and ask if there are any, if you need me to clarify anything about this. Awesome. Okay, so in future classes, I'll just be like, every nerve has a body with dendrites on it. I'll probably like pull this thing up or at least hover over it for you. It has a long axon. So most of the many times that it's wrapped in Schwann cells, which provide myelination or form the myelin sheath. At the end, there's an axon terminal. Let's see what this is. We're not going to be going into deep dives all the time, but the first time we cover something, it's a good idea. Okay, so I'll just show you this one time. All right. So this is a close-up of the Schwann cells that provide myelination, right? So this is the red thing is the axon, and the green thing is the myelin sheath. And here you have the red axon. It's a cross section, right? So they cut right through it. They make this cut that splits it into like they make a transverse cut or a horizontal cut. And you're looking, they cut it like this, and then they open it up, and you're looking down into it like that. Hopefully that makes sense. Let me know if it doesn't. And so you're looking down into the axon, and wrapped around the axon is this living thing, the Schwann cell. There's the nucleus of the Schwann cell. And so you can imagine that like with all this like cordage or all this fatty wrapping around it, nothing's going in or out of the cell. But the way that, let's see how I see this. Since nothing can go in or out of the cell, the net effect is that instead of the action potential moving down smoothly down the axon, this is an axon, an unmyelinated axon here, no myelin, and this is an axon here which has myelin with these green drawings, these green things. And so instead of it moving down, it skips like that. So instead of having, let's say I'm seeing three nodes here, not nodes, I'm seeing three gates which allow, or three channels which allow sodium and potassium to come in and out. Those are charged ions that carry negative charges inside or positive charges inside, depending on what's happening at the time. So I'm just going to pick a number that's multiple of three. I don't need to explain all this to you. I'm sorry. So instead of having to travel like 6 millimeters, the effect of 2 sections of myelination is that the action potential has to travel 3 millimeters instead. So it makes it much more efficient. And there's actually a graphic which is pretty good for this. Yeah, so when an action potential, when charged particles start to move through the axon, there are moments where some of the sodium has to go out, and then some of the potassium has to come in, or vice versa, depending on what side of the charge you're on. It would be more sodium in the front, more potassium in the back, but that doesn't matter. But if there's only 3 places rather than 6 where those ions can be exchanged, the action potential has to keep moving. So another way of thinking of myelination is it's like an express line where there's, instead of 6 stops, there's 3 stops. You don't have the opportunity, where you are the ions, and you don't have the opportunity to get off every other stop. You have to go like every 3 stops, every 4 stops. And then there's another part of this graphic. Set your playback speed higher. And there's another part of this graphic which is pretty right there. See, it skips over this large section. So the effect of myelination is to increase the speed of the action potential or the transmission, the nerve transmission. Now, I'm not going to go over this, the propagation of an action potential every class, but I will give you the terms again, just so that you hear them. And, my goal is to give you the foundational information so that you have context and understanding like one time, and then just to hammer it into you, just to get you to drill it over and over again, using like call and repeat. So you have the verbal, using visual, using kinesthetic or tactile, right? Movement, kinesthetic. So if you have any questions about like what is happening here, the nature of what's happening, this is the time. So feel free to just unmute and call out. All right, so let's get into a little bit of what actually happens with action potentials. Action potentials are a result of sodium, which is positive. Sodium is positive, moving into the cell. A cell's resting state is predominantly negative. When a neuron or a nerve cell or a muscle cell, for that matter, we're primarily interested in nerve cells and muscle cells. When they're at rest, not propagating and not transmitting anything, their measured charge is negative 70 millivolts. That's called the resting state. And you may not have to remember or recall negative 70 millivolts being resting state, negative 55 being threshold, but you should at least hear them once or twice. And you definitely will have to know the terms resting state, threshold, depolarization. Those three are really important. And you may have to know repolarization as well. So the way that nerve cells and muscle cells change from negative 70 millivolts to negative 55 millivolts is by taking positive ions into their cells. So they're negative 70, and then they have all these little gates that open. They have all these little gates that open and allow sodium and sometimes potassium to come in, and that produces a more positive charge in the cell. And when the cell becomes more positive, it propagates an action potential down the length of the axon. And these gates are inevitably drawn as like two dash or two like hash marks right next to each other. So these gates allow sodium and they allow potassium to come in or out, and they allow chloride and I'm missing one. It'll come to me in a minute. Okay, it'll come in. It allows chloride and one other particle, calcium, to exit. So they open and close. The gates open and close as a result of some kind of stimulation. It can be an action potential changing the charge of the surface, and they can open due to the change in voltage, or it can be a chemical in the area, like if a nerve cell releases acetylcholine and it touches a muscle cell, the muscle cell's channels will start to open, and that will allow sodium to flood into the muscle cell, right? Or it can happen as a result of deformation, as a result of stretch, which is really important to us as myofascial therapists, because it's mechanically gated or stretch or deformation channels that we are opening when we do any kind of myofascial release, any kind of stretching, whether it's active stretching or passive stretching or whatever. There's mechanically gated channels. We'll go over those in a moment. So as a channel, for whatever reason, as it opens and allows sodium to come in, the resting state, the negative charge of the cell starts to change and starts to become more positive than negative. They're definitely going to ask you that. The resting state goes from negative 70 up to negative 55, and this is called becoming polarized, or becoming more negative, more positive, becoming more positive, or becoming less negative. Polarization is more positive and less negative. Polarization is more positive and less negative. All right. Yeah, ions are charged particles. And if you split any kind of compound, for example, sodium chloride, which is table salt, if you split that, it becomes unstable, and each of those has a charge. Like chloride has a negative charge and sodium has a positive charge, which is why they stick together to become sodium chloride when they're close enough to each other or in water. So if you split them up, they become what are called ions, right? Technically, a positive ion is a cation ion, and a negative ion is an anion. I don't think you need to know cation and anion for the exam, but if you hear the terms, at least you know what they are. And each has a charge, right? And so when we look at the propagation of an action potential, or the movement of a nerve impulse, or the excitation of a muscle, or muscle contraction, what we're really talking about is we're talking about the movement of positive ions into the cell. So the cell, whether that's a nerve or a muscle, becomes more negative. It becomes more positive and less negative. So you can see down here, it starts at -70, and then positive ions rush into the cell. The cell becomes more positive and less negative, more positive and less negative, right? And then when the nerve or the muscle cell gets to a certain point called threshold, which is -55 millivolts, when it gets to a certain point, it has to move. It like has no choice, right? It's like when you get a magnet close enough to the other magnet, it has to push the other magnet away or draw it towards it. That's a type of threshold with magnets. And nerve cells and muscle cells also have a threshold where they can start to take in sodium and potassium, and they can start to accumulate a positive charge, and nothing will happen until there's enough sodium, potassium in there. And then, boom, it has to move. Those ions have to like move down the axon. They have to move throughout the muscle fibers. Okay, and as the positive ions start to move into the cell more and more and more, it reaches the threshold, -55 millivolts, and then you get the propagation of the action potential. You get the excitation of the muscle, the contraction of the fibers. You get sometimes sodium moving in, you get potassium moving out, you get chloride moving out, chloride moving in. It just depends on what's happening. When the muscle contracts or the nerve fires, the action potential propagates, or the muscle excites and contracts, it's called depolarization, right? So once the cell reaches threshold at -55 millivolts, the charge has to move, particles have to move, and that's called depolarization. Depolarization. It'll peak at some point where it'll reach like maximum positive charge inside, and then all those positive particles start to flood out because the body wants to balance itself, right? The inside and the outside of the cell, they want to have like the same charge. And as the inside of the cell starts to become a lot more positive, it naturally wants to return to being the same amount of positive and negative on both sides of the cell. If anybody is lost, please let me know. And after depolarization, after the maximal accumulation of positive particles inside, positive ions inside of the cell, those ions start to efflux or start to flow out of the cell, and the cell returns to a negative charge. That's called repolarization. So you have the resting state, you have threshold, which is a gradual depolarization, and a point at which all of the particles have to start to move. Threshold is also called the all or nothing point. You have the depolarization of the axon or the nerve cell, the depolarization of the muscle cell, and then you have the gradual return to homeostasis, which is repolarization. So we'll be summarizing in the future by saying all nerves have a body with dendrites and axon, often wrapped in Schwann cells to myelinate the axon and an axon terminal. What happens with the movement of electricity in neurons or nerve cells is called action potentials. It's called the depolarization or the propagation of action potentials. What happens in muscle cells is called excitation. Action potentials in nerves, excitation in muscle cells. Okay, those happen as a result of the influx of sodium and potassium ions moving across the cell membrane. That always means moving into or out of a cell. So moving into a nerve, moving into a muscle cell, or moving out of a muscle cell, moving out of a nerve. Don't forget, keep in mind that sodium and potassium, chloride and calcium, but those are ions. Those are particles that are like unmated, unpaired. So they have a charge because they're a little bit unstable. And the body uses that to its advantage. Key terms for you to keep in mind is that a neuron is a name for a nerve cell, and in a muscle, when a muscle meets a neuron, that's called the neuromuscular junction. Neuromuscular junction. That's also called the synapse. The synapse. Yeah, so where neurons meet muscles, that's called the neuromuscular junction. Also called the synapse. Also, and the space between them is called the cleft. And what happens at that neuromuscular junction is definitely something that you want to know. Okay, so here we have an image of a neuron. Here's the brain and spinal cord. Always get oriented right. And we have a neuron extending down to an effector organ, and this is like a muscle cell. It's like the biceps in the image, right? So you have an action potential coming down this axon, and it terminates at the axon terminal. Now, the area where the axon terminal starts to interact or touch the muscle is called the neuromuscular junction. So this is the neuromuscular junction. There's a structure on the muscle called the motor end plate, right? Because it's receiving motor impulses, motor like movement. It's called the motor end plate, and it's the job of the motor end plate to provide a receptive area for the axon terminal. So your action potential comes down the axon, arrives at the axon terminal. Remember, this is like electricity we're talking about. These are charged particles we're talking about. And you're going to see like this light feature come down, and it's going to depolarize or change the charge at the axon terminals. And that's going to change the charge at the motor end plate. And that's going to cause the muscle to contract. It'll cause excitation, which then causes contraction. There's a process which happens, a 7-part process, which we can go over like once or twice more throughout the whole class. So you have the movement of the action potential down the axon to the axon terminal. And you should repeat this with me. The movement of the action potential down the axon. The movement of the action potential down the axon arrives at the axon terminal. Arrives at the axon terminal. The movement of the action potential down the axon arrives at the axon terminal. That changes the charge of the axon terminal. It changes the charge of the axon terminal. When the charge at the axon terminal changes, these channels that allow calcium to go in and out, they start to change shape as a result of the change in the charge. Those are called voltage-gated channels. Remember, there's 4 kinds of channels. One of them opens and closes in response to the change in the charge, depolarization or repolarization of the axon terminal. So these calcium channels open after the action potential arrives at the axon terminal. Say that with me. The action potential arrives at the axon terminal. It depolarizes the axon terminal, which opens voltage-gated channels, which opens voltage-gated channels, which opens. I can see 2 people and no lips moving. I see 3 people, including myself, and only mine are moving. Can I see at least three lips moving, please? I don't mean upper or lower, I mean pairs. The action potential arrives at the axon terminal. It changes the charge of the axon terminal, depolarizes the axon terminal, which then opens the voltage-gated calcium channels. It opens the voltage-gated calcium channels. This allows calcium to flood into the axon. There's calcium at the neuromuscular junction, like in the cleft, in the space, just hanging out there in the cellular fluid. And the calcium floods into the axon terminal after the voltage gated calcium channels open. The calcium floods into the axon terminals. When the calcium enters the axon terminal, it touches these vesicles, which are just like storage, like little miniature cells, storage cells. And when it touches these vesicles, the vesicles, they break down. It's called synaptic vesicle because it's a vesicle that hangs out right next to the synapse, like in proximity to the synapse. And a lot of these store acetylcholine in this example, in the example of a neuromuscular interaction. So the calcium goes into the axon terminal, it interacts with the vesicles, the synaptic vesicles. The synaptic vesicles break down, which releases acetylcholine. So we have an action potential, we have the axon terminal, we have voltage gated channels, and we have calcium. And now we have acetylcholine. And the acetylcholine diffuses, wait a minute, let me get this right, it doesn't diffuse. The acetylcholine binds to receptors on the muscle, diffuses out of the nerve, goes across the cleft, diffuses out of the axon terminal, out of the nerve, goes across the cleft, binds to receptor sites on the muscle, on the motor end plate. And as the acetylcholine binds to these receptor sites, sodium channels start to open, and they allow sodium, which is red, they allow sodium to flood into the muscle cell. Sodium is positive, which depolarizes the muscle cell. The muscle cell goes from negative 70 millivolts up to negative 55, where it reaches threshold, and then it propagates an action. It goes through excitation. And in excitation, look under the sink. I'll be right back. Okay, I don't know about anybody else, but I'm not amused. I know you guys have a lot riding on this, and just to be frank, if somebody can't find the toilet paper from now on, or they can't get into the meeting, that is not the problem of the collective who is here and present. So, acetylcholine binds to these sodium gates, opens the sodium gates, allows sodium to go into the muscle, which causes excitation in the muscle, which is kind of like a form of depolarization in nerves. Depolarization in nerves, excitation in muscles. And then the muscle cell, as it excites, sends electricity along its fibers, which causes the muscle cells to contract. So that's basically the whole process. It's an action potential arriving at the axon terminal, the opening of voltage-gated calcium channels, calcium coming into the axon terminal, the breaking down of vesicles that then releases acetylcholine, acetylcholine diffusing out of the axon terminal, across the synaptic cleft, across the neuromuscular junction, same thing, binding to these chemically gated sodium channels, which allows sodium to flood into the muscle cell, which then causes excitation in the muscle. Excitation causes a muscle contraction. And then the last thing that happens is that the acetylcholine drifts away from the receptor sites, and it has to degrade. So some of it will be broken down into two chemicals. I forget the names of the chemicals, it's not really important, but it's broken down into two chemicals, so that basically it's a different shape now. It's not acetylcholine, it's two acetylcholine precursors. And yeah, acetic acid and choline. And those cannot bind to any receptor sites and, cause muscle excitation or nerve depolarization, stuff like that, right? So then it has like no physiological action once it's broken down. Some of it will be reabsorbed and some of it will just drift away, and other cells will recycle it. Okay, now that's a lot. Like to understand the process of muscle excitation, muscle cell contraction, the neuromuscular junction, the events that happen through the nerve down into the muscle, that's a lot. Does anybody want to see it again? Does anybody want me to go over it again? Is there anything you guys want to ask? Otherwise, what I'll give you next time is going to be something that sounds like the place where neurons and muscles interface or connect is the neuromuscular junction, also called the synapse or the cleft. There's the motor end plate. Recall that excitation of muscle fibers involves or requires an action potential arriving at the terminal, and then there's a series of 7 events, including the influx of calcium, the outflux of acetylcholine, binding of acetylcholine to the muscle that allows sodium to influx into the muscle, that then depolarizes or excites the muscle and then causes a contraction. That's what you're going to get next time. So if you guys want anything more specific now, feel free to ask. This is a couple things about that process which I'd like to discuss, which we just need to discuss like 1 or 2 times, are osmosis and diffusion. Remember I said that acetylcholine diffuses across the synaptic cleft, right? And diffusion, what happens in diffusion is that particles move from a place of, they always say like a place of higher concentration to lower concentration, but what does that really mean? Well, if you burn incense or you spray air freshener or perfume, something scented, those are particles, right? A lot like the stuff that we're seeing here on the screen. So if you spray that stuff in the air in your room, eventually the opposite end of the room will smell exactly like the spot where you sprayed it. Maybe not as strong, but if you walk through the room, it'll all smell about the same intensity because the particles will have diffused, right? They diffuse across the room. So there's like no air freshener on the left part of the room. You spray it on the right part of the room, it wafts over, it diffuses over to the left and starts to be distributed evenly, because that's what particles want to do. They want to be in like even or homeostatic relationship with all the particles around them. And when they're not, they start to move, they start to disperse, they start to diffuse. Diffusion happens in the cleft once the acetylcholine is in the fluid between the nerve and the muscle. It just like diffuses like sand in a pond. It just starts to settle down toward the bottom. It starts to settle down toward the muscle. So diffusion happens when there's no energy required and there's no movement across a cell membrane. But when acetylcholine goes from being inside the nerve cell to getting outside the nerve cell, that's a special kind of diffusion that's called osmosis. So osmosis happens when any kind of like chemical or any kind of particle goes across a cell membrane. So imagine that you have like, let's say 500 acetylcholine particles in all these synaptic vesicles, and they bust open and now there's 500 acetylcholine particles circulating in this nerve axon terminal. And there's like 10 in the synaptic cleft. The acetylcholine particles will want to go from the area where it's most concentrated in the 500 inside the nerve into the area where it's less concentrated, which is the synaptic cleft, where there's like 10 acetylcholine particles. And the way it has to get there is to go across the cell membrane. So anytime particles cross a cell membrane, that's called osmosis. Osmosis is defined in this way that's like very abstract. It's the movement of particles from higher concentration to lower concentration across a cell membrane, across a membrane, not a cell membrane, across a membrane, across like a semi-permeable membrane, across a semi-permeable membrane. It allows some things in and other things, like it'll allow calcium in, but not sodium. Solutes or ions, for our purposes, we're talking about stuff that's dissolved in water. So the solutes or the ions that we really need to know about are like potassium, chloride, sodium, calcium, also acetylcholine. Sometimes we're gonna have to think about things like thyroxine, T3, T4, different kinds of hormones as being solutes. So solutes are the particles, and the solvent is the liquid. The solvent can be the liquid inside the cell, can be the liquid outside the cell, it can be blood. Now, how do you remember solvent and solute? You definitely need some way of remembering this. So there's this nice little like mnemonic device, okay? A thief broke into a building and filled a bag with loot. So that's solute. Then the police came. The thief hid the loot in a vent so he wouldn't get caught. The solute goes into the solvent. The solute goes into the solvent, right? He stole the loot. He put it into a vent. The loot goes into the vent. The solute goes into the solvent. That's called a solution. His solution was to put the loot in the vent. That's a solution. Okay. That's about enough for tonight. We'll get to intrafusal and extrafusal next time. You're going to hear me summarize like solute.